only thing I would have to tell you that what did you say about Texas people in your lecture? You said so. So the
I don't want to generalize. I apologize. I don't mean to
no,
offend
no,
you.
no, no. You don't need to apologize. It was just funny for me to say that people in California are thinner than people in Texas. Did you come up with these statistics, or you just made it up because you want
That
to
is the perception. It's not reality.
make so so yeah. I'm just saying that so you only recruit people who are thinner then.
No, 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 no. That is just the perception. I didn't want people to
No,
think
no,
that
that's fine.
that is true. Yeah, and I don't mean to
No,
to
I
stereotype
just
or
thought, yeah,
generalize.
I just thought it's funny. Anyway, especially that I'm from Texas and we have several people from Texas here in the call, so I'm sure that, and we all thin, by the way. I'm the only one who's like having a belly in all of them. But anyway, so we have David here, we have Madhavi, Batnana, we have Bella. They are all thin, so I don't know where you come this with this perception from. So maybe from me. I know it's from me probably. Anyway, so I have a question for
Sure.
you, and maybe also David Fitzer is with us. Have you ever, guys, thought of, since we need to further characterize the positive findings, ultrasound 3 category,
Hmm.
do you guys have you ever thought of just doing this characterization for the positive findings with contrast enhanced ultrasound on the spot and save patients time and
Right. That would be really great. Yeah. And in fact, some places do that. We are unable to do that at Stanford at this point because we need to get a physician order, and there's a little bit of logistics involved. They get scanned, for these HCC screening and surveillance exams. They get scanned at outpatient imaging centers mainly, and usually early in the morning because they're MPO. So we don't necessarily want people to be fasting all day waiting for their ultrasound. So we try to do them early.
Mhm.
Um, and because of the fact that ultrasound threes are pretty rare, we don't have, special slots available for contrast enhanced ultrasound. But I think it would be really wonderful to be able to, if they're positive, to go right straight to a contrast enhanced exam.
Mhm.
Since they're visible on ultrasound, it makes sense to do that. And I know that some places are able to do that. We at Stanford have not implemented that. But if anyone has implemented that, then I would love to talk to you to see
Sure.
how you got around the logistics of it.
Yeah,
David,
it's
David.
David. Yeah, I'll talk about more about this on Friday as one of
Oh,
the
perfect.
workflow getting into the contrast enhanced ultrasound LI-RADS system. But aside from that, I have to say we've been fairly successful implementing that here, at least at our Parkland County Hospital system, because all radiology is performed in one spot, and all exams are still checked out with a radiologist. And we have an overflow room in radiology. So if we identify any observations that warrant further characterization, and this could be in obviously a patient at risk for HCC or not, for liver or kidney lesions, we basically send the patient down the hall to our common nursing area. The nurses start an IV on our patient just like they would for CT or MRI patients. The patient comes back to our overflow room and we squirt contrast and get the answer right then and there. And obviously this is very cost effective. The patients love it because a lot of them are taking public transportation and have trouble getting off of work. And so getting the answer the same day and the same appointment is great. And then obviously our ordering providers love it because they can get a jump start on the downstream management of these patients. And I know Amit has been pushing us to implement this, and we were on track before COVID.
Mhm.
And
Wow.
we had started it and done pretty well. One of the things about pre-authorization and ordering, Dr. Kamaya, that we got
Hmm.
around is in our
Hmm.
electronic medical record system, we added an order entry question to all of our applicable ultrasound orders that
Hmm.
basically says, do you allow the radiologist to add contrast if warranted? And it's defaulted to yes. And so we use that order entry
That's
question
perfect. Yeah.
to activate an ancillary order. And our billers and coders have been fine with that. And
I
so
see.
we don't need to then track down the ordering provider or get pre-authorization or anything. They're basically ready to go. So for those of you who have a good integrated electronic medical record system, consider adding a similar order entry question to your liver and renal ultrasound orders.
Perfect. Thank you very much, David. Thanks, Aya, too.
Thank you, David.
So we have a question from Italy, from Dr. Roberto Canella. Roberto, buonasera.
Good morning, everyone. Thank you for the very clear overview about the ultrasound LI-RADS. So I'll start with a comment regarding that. In my institution, the LI-RADS algorithm from CT and MRE as well as SEALS is quite well used, but there is some difficulty to use the LI-RADS ultrasound algorithm. In my opinion, the reason for that is that most of these patients who undergo surveillance are scanned and ultrasound is performed by the hepatologist and not actually by the radiologist. And so my question is, if in the future there will be a possible integration of the ultrasound LI-RADS with the clinical guidelines as it happened with the MR and CT to increase the utilization also by non-radiologists.
That is your, okay, so I'm sorry, what is, your question is whether or not we could recommend that, or is that a suggestion?
No, like right now, like MR and CT ultrasound, MR and CT LI-RADS is integrated in the SSLD guidelines, but I think this is not happened for the ultrasound LI-RADS. So
right, that is something that we would like AASLD to incorporate. You know, the AASLD actually does incorporate the ultrasound category score of A, B, or of 1, 2, or 3, but they have not officially incorporated the visualization score. But that said, Amit, who is in the AASLD group, he really advocates the visualization score, and so I hope that perhaps in the future this will get incorporated as well.
Okay, thank you very much, Roberto. Thanks, Aya. We have several other questions, Aya, and we have 3 questions from Claude and 1 question from Victoria. And of course, I will start with Victoria. Dr. Cherniak.
Thank you, Khaled. Aya, thank you for this phenomenal presentation. I do have a question. So Amit, when he presented his lecture, discussed some data that when patients get non-diagnostic ultrasound, if the ultrasound is repeated, you actually, in a large proportion, you can get the exams to be diagnostic. Have anyone evaluated this this approach using visualization score, and to see if you know, if the patients?
I think his study was actually, his study was looking at visualization scores.
So it was.
Yeah, his study was looking directly at visualization scores. He said that if they had, I mean, I don't want to speak for him, so if he happens to be on the line, I would love for him to barge in and say what he meant. That my understanding was that he and David looked at visualization C patients. And in those patients who had a repeated ultrasound, about 50% turned out to be visualization A on a follow-up examination. So visualization score is not static. It can change on follow-up exams. But people who have visualization A's tend to stay A's. So it tells us that, you know, the reasons for visualization C, they're quite myriad. There's some that don't change and some that can be improved. And one thing that I forgot to mention is that we do not recommend doing a screening and surveillance ultrasound in an ICU patient or in an ER patient or an inpatient. And the reason for that is that those patients may or may not be NPO. their condition is such that they may not really be amenable to rolling and moving, and so the exam is not going to be optimal. And when you're doing a surveillance ultrasound, you really need to make sure that you optimize for everything. Otherwise, you're going to miss stuff. And so we do not recommend doing a screening and surveillance ultrasound in ICU, ER, or inpatients.
Great. Another question is very, very practical. We've had a very difficult time trying to convince our sonographers to implement ultrasound LI-RADS. Is there educational material or compilation of database that can be used to kind of support this move?
So I don't think it's necessarily the sonographers that need to be on board. It's the radiologist. The sonographers.
Radiologists, yes, radiologists.
Yeah, the sonographers should just do what they are doing with their ultrasounds or whatever protocol that you have. So we just have basically we have a hepatoma survey protocol at Stanford, and I think most places have that as well. And what we have done, and most places do, is if you have a hepatoma survey, to have a standardized report that automatically pops up in your dictation system, where you just put in the blanks, and it really helps guide the radiologist. And then we have a little thing at the bottom of the report that provides a key. What does ultrasound 1 mean? What does ultrasound 2 mean? And a reference, so they can go to the ultrasound LI-RADS core, which is available online to anybody, so that people have some sort of reference and can see that this is something that is recommended by LI-RADS. So the first time that our hepatologists saw this, at first they were like, well, what is this? They were a little bit confused, but once they figured it out and realized and got used to the structured reporting and how we were reporting, our hepatologists love it. They get a much better sense of what's going on, how well we can see the liver, and so they feel like if somebody has a visualization, they do pay more attention to those patients, and they may alter the way they get surveillance done, but they make that decision on in conjunction, weighing the pros and cons of the patient's condition and other factors. So they really do appreciate that. In the past, prior to ultrasound LI-RADS and the visualization score, we would have a number of radiologists, say, oh, this patient has cirrhosis, therefore I can't exclude anything. And then it just leaves the clinician in this conundrum, like, well, the radiologist is telling me that the ultrasound is not good, but sometimes it was like a knee-jerk caveat that that they would put in every single exam. And I don't think that is fair to the patient, because a large majority of patients are good ultrasound candidates. And so if they are, then they should undergo ultrasound. And of course, there are going to be some patients who are not good ultrasound candidates. And I think it's important to identify those patients because they may benefit from, say, an abbreviated MRI or some other strategy.
Hey, Aya, can I add something?
Sure.
And I don't mean to rain on your parade. I think that's amazing stuff. But I just wanted to add that, building on Amit's discussion about our first study on visualization, that was done pre-LI-RADS. And so
that's right, yeah.
We used a quality score that ended up being very similar to the visualization score. But we recently retrospectively evaluated 10,000 liver ultrasound reports, extracting the liver visualization and LI-RADS categories. And that was presented at SAR, and we're building that manuscript now, but it did very well support Amit's original findings that many of the patients who have visualization score C end up going to a B or A on a follow-up examination. And so we know that, whether or not the patient's fasting or not may have to do with that technologist experience, technology availability, and whether or not the patient's inpatient or outpatient also seems to make a difference. And so we're looking at those variabilities from between time points, and also other factors. So etiology of liver disease, body habitus, age, race, gender, things like that, to kind of help build a model of which populations of patients may continue to benefit from ultrasound and which of those we may direct to another screening modality. And so stay tuned for that manuscript. And then we're looking at that same data in a semi-prospective abbreviated MRI versus screening ultrasound head-to-head study, which should be completed in a year or two. So we are collecting data to help support downstream management guidelines based on the visualization score. So everyone should just stay tuned.
Yeah, that's great. I look forward to seeing those papers.
David, that's amazing.
I think that'll really help a lot.
Yeah.
Very impressive. Yeah.
Yeah,
really
that's
important.
very good. We have two superstars here, Aya and David. So, last but not least, of course not least, Dr. Serlin, you have 3 questions. I'm just trying to look in the audience if there are any questions before yours, but you can actually start now giving the 3 questions, please.
Yes, no, okay, well, thank you. First of all, I'd like to start again by congratulating Aya on her fantastic lecture. We were trying to figure out what the best adjective was, and we weren't sure if it was superb or spectacular or fabulous or outstanding, but anyway, it was really, really good. I actually want to start with a comment. My comment is that for those people in the audience who are radiologists, but who are finding that there's some of their radiology colleagues are opposed in some way or resistant to the use of ultrasound LI-RADS, I'd like to point something out that you may not have thought about, and it's the following. That in the last 15 or 20 years, when it comes to the diagnosis of HCC, the first imaging criteria, so let me repeat this, the first radiology criteria for the diagnosis of HCC were made not by radiologists, but were made by hepatologists. So just think about that for a while, that the first criteria for the radiologic diagnosis of HCC were not made by radiologists, they were made by hepatologists. To my knowledge, the ultrasound system that Aya and her group have created is the first time that radiologists have been the first to develop an imaging-based system for HCC. So I very strongly believe that radiologists should support Aya and her group in using ultrasound LI-RADS, because if you do not, trust me, the hepatologists will come up with their own system, and then there will be the challenge or the pressure to start using a system designed by hepatologists for radiologists. So I think all of us should really feel very grateful to Aya and her team for developing a system by radiologists for radiologists. If you don't like ultrasound LI-RADS as you start to use it, that's okay. Just let us know. We'd be very interested in your feedback. So that's one comment I'd like to make. Now, I don't have the same questions I had before because some of those questions were actually asked by other people on the call. So I have 2 follow-up questions for you, Aya. One is, and if you mentioned this, and I apologize, but is it yet known what the reader agreement is for the visualization score? Has that been studied yet, or, and forgive me if you already mentioned it during your lecture?
We don't have that, and I think that's a really important point. I anticipate that the visualization score is probably going to have a lower agreement than the actual ultrasound categorization score. And I think in part, we are probably to blame in part for that because of the definitions that we set for the thresholds between A and B and C. We set those thresholds to be a little bit vague to some extent because we didn't want to be too dogmatic about what is B or what is C. I mean, you know, essentially, we kind of took a broader perspective of of visualization where, you know, C is basically an exam where you really think this exam is not going to be useful at all. Like it has no diagnostic value. And so there's sort of this spectrum, and you know, I think it's going to be hard when there are exams that are like right on the border. So we have not evaluated that. But as people do more research, I think that's definitely a good topic to look at.
Okay, great. My second question is related, and you may not know because I believe you said that this was data presented at the RSNA in 2019. I think it might have been by the Michigan group, so it's possible you don't know this information yet. But in the small percentage of LI-RADS subthresholds that ended up being HCC, do you know what the time frame was between the ultrasound and the diagnosis as HCC, or you don't yet know that information?
I don't know the details to that extent. I just know that the number of HCCs were somewhere around 3%, I believe, that were actually HCCs, and then about 0.9% were malignancies, and then about 1.2% were LI-RADS 3. So yeah, actual HCCs is very low in the subthreshold group, and that really helps to support our rationale that subthresholds should go on to short interval follow-up because the incidence of HCC is actually quite low.
Right, and the reason I'm asking is that if it turns out that the time frame from the initial detection at ultrasound to the eventual diagnosis as HCC is long, that would be further support. So in other words, if you know, if they don't actually become HCCs for another year or so, that would be yet even more support for the thresholds you guys have come up with. Okay, so those are the only two questions I have. I'd like to make a couple teaching points if possible, but only if that's allowed by you and Khaled. But also, are there any other questions from the audience that have come up? Because if there are, we should get through those questions.
No. Go ahead, Claude. Go ahead.
So Aya, is it okay with you? I just would like to make two teaching points that are not related.
Please, I'd love for you to do so.
Could you show you showed some really beautiful cases. So one was an ultrasound example. I think it was of architectural distortion with the refractive edge shadows.
Do you want me to go to that? Let's see.
But I want to make a comment on the CT. Yes, this is it. This is an amazing case. Okay. So this is a question that has come up earlier on the CT side, which is this the question about infiltrative tumor and how to categorize it. So if you look at this CT, in this particular case, as Aya pointed out, there's tumor in vein. There's actually enhancing tissue within the lumen, in this case of the expanded portal vein. And so you would categorize this as LR-TIV. Now then you would look at the liver parenchyma and you see that the liver parenchyma has some heterogeneous enhancement on this late arterial phase image, but doesn't actually show arterial phase hyperenhancement. If you look at the areas of enhancement within the tumor, it's enhancing to the same extent as the background liver, but not more than the background liver. So if there was not a TIV, imagine you had this exact image, but no TIV, what would you say about it? Well, you can't call it a LI-RADS 5 because it's not hyperenhancing more than liver, so you would call it a LI-RADS M. So if there was no TIV, you would call this a LI-RADS M. Now, because it's not a targetoid mass, and we know that infiltrative tumors are usually HCC, you could say LI-RADS M, probably hepatocellular carcinoma. But you wouldn't say definitely hepatocellular carcinoma because it doesn't meet the criteria for LI-RADS 5. So I hope that was helpful to some of the people who were asking questions about LI-RADS M in the past and how to categorize infiltrative tumors. Now in this case, you would say it's an LR-TIV, and because the LR-TIV is associated with an infiltrative tumor, you would say LR-TIV, probably due to hepatocellular carcinoma. You don't know for sure this is a hepatocellular carcinoma, but you think it's likely a hepatocellular carcinoma, and so you could dictate it that way. If Don Mitchell was on the call, he might point out that if you had an AFP and the AFP was 15,000, at that point, the management team might decide, you know what, this is an HCC, we don't need to biopsy it. I'm sorry, I think someone was going to say something.
No, he's not in the call. No, I don't think anyone would say something. Okay. Yes.
Then can we go to the next slide? I think it was the LI-RADS M.
Sorry.
Forgive me, it may not have been the next slide, but there was a slide where you showed a LI-RADS M. Forgive me, I don't know where it was.
This one. Mm-hmm.
Yes, this one. Oh, this is an amazing case on MRI.
Thank you.
So what I would like to point out is on the top row, we have an early arterial phase. And then you called the one on the top right, you called it a portal venous phase, and you may be right, I don't know, but it's
it's a late arterial, you're right.
Okay.
I just showed multiple phases here.
Right, but what makes this case so interesting is that on the very early arterial phase, it has rim enhancement, which is LI-RADS M. Notice that the lesion fills in on the late arterial phase. So if you only had the late arterial phase. So I know that at Stanford you have sophisticated technology, and this is probably a disco that you have, and you have multiple arterial phases, and you just are showing us two. Mm-hmm. But at many institutions you're only going to get one arterial phase, and it's possible the only image you'd get for the arterial phase is the top right, in which case that's not rim enhancement, that is diffuse enhancement. But you would not call this an HCC, because if you look at the more delayed images, the mass remains enhanced. So interestingly, if you didn't have the first image on the top left, you might end up equivocating between LI-RADS 4 and LI-RADS M. If you could convince yourself that there's delayed central enhancement, you'd call it a LI-RADS M. If you couldn't convince yourself that it's delayed central enhancement, you'd call this a LI-RADS 4. Now, and I guess that's about as far as I can take it, since I can't see this image on PACS. I'm just looking at it on your PowerPoint image. But what I wanted to let the audience know is that we're very interested in this phenomenon that's illustrated in the top panel of images, which is something that we're thinking of calling transient rim enhancement. This isn't, to my knowledge, there's no literature on this topic, but I think this is an interesting phenomenon that you might have rim enhancement in one arterial phase, but may not have rim enhancement in another arterial phase. And the question then becomes, if in fact you do that, because more and more of us are going to be doing multi-phase arterial phase imaging, we might start seeing this in our practice, and how do you deal with this sort of thing? I don't have an answer. I'm simply pointing out that this is an interesting research question. And if anyone is interested in doing research on this topic of transient arterial phase rim enhancement, please contact us. We'd be very interested in working with you.
That's great. Thank you very much, Claude. And thanks, Aya, for this informative and really, really updated, cutting-edge lecture. Thank you very much for that. Again, thank you very much. I mean, if you look at Aya's picture and you can't correlate it with a great accomplishment she had, you would expect a person who's like a 7-year-old radiologist now retiring, but Aya is still very young, and with that she's having these huge accomplishments. Wish you all the best. Thank you for humbling yourself and speaking to us.
Thank you, Khaled, for inviting me. It was really fun.
Appreciate that.
See everybody virtually. Thank you.
Thank you very much. So with that, I would conclude the session, and tomorrow we're having another exciting session with Dr. Avinash. And he's going to talk, I will need to practice pronouncing his last name. So tomorrow you'll find me probably pronouncing it correctly after taking a long time in pronouncing it and practicing that. And he's going to talk about technical recommendations. And another exciting day on Friday with David Fitzer to complement Dr. Aya Kamaya. He's another superstar. He was speaking to us today in the discussion about contrast enhanced ultrasound, which is a hot topic, and we'd be all looking forward to that. Thank you again, Aya, and everyone for attending, and I'll see you tomorrow.
Thank you so much. Thanks, everybody.
Thank you, Aya.